what you're doing, what your research is focused on. And this morning you heard from Dr. Pravdeep also. So within the hypertension care or NCDs in general, what do you see are the, say, top 3 or 4 areas or research gaps that need to be filled if you want to scale up? I mean, let's think in terms of scale.
Thank you for that. Thank you for that question. And hello everyone. I'm Archisman. I manage a network, a non-profit called Great Council, and the model is that we are network with medical colleges. So it's a hub and spoke model with about 88 medical colleges on board, and the entire philosophy is collaborative research. So what we do is we are very much networked with faculty members in departments of community medicine and public health, and with young residents and senior residents and students in medical schools, so that it's a long-term investment, trying to build their capacity. So when we are interacting with academia, we behave as hardcore researchers and people with development side flavors. But the other dimension is that we engage very widely and very strongly with development partners. So I've had the fortune of working with Dr. Baral, and so what we do is we work with them, and they are very much into service delivery and program strengthening. We do not have that bandwidth, but we have access to their knowledge repository, so they are on-the-ground faculty members sort of thing. So that's the exchange we do. In the hypertension domain, we have a project with Banaras Hindu University, Institute of Medical Sciences, and that again is a mobilization exercise where we are trying to build a pan-India consortium of faculty members and residents who will be committing themselves to hypertension research. And through this project, we have also built a non-communicable disease secretariat at IMS PHU, which has other disciplines. So the approach is a multi-morbidity approach. So it's not just about hypertension, because you get patients with diabetes with hypertension, or some endocrinological problems, other endocrinological cardiac problems. So many other, like multi-morbidity approach. So that's a NCD secretariat that also provides multidimensional inputs into our public health approach. So we want to bring in that incisiveness into that clinical incisiveness into the public health approaches we do. So that's the broad purview about the organization. Now coming to the question that you asked, how do we ensure that evidence-based practices get translated to action on ground, and what could be the priority research areas we could work upon? Now, the times are really fantastic, because health has really emerged as a very important priority for all governments, especially the post-pandemic governments. Now, and that means if we partition research into 4 broad categories: the discovery element, that people are committed to discovering new things; the description elements; and then the delivery of health services and development. That means you are delivering something, you add some more features to it. So this side of the story, the delivery and development, will always be a priority for any government, because that's linked to the goals, that's linked to performance of programs. And in that space, we are seeing very rapid evolution in terms of the NPCDCS program, because it's transforming much. And we have changed our approaches. So from opportunistic screening to population risk screening, now method has been added, cancers are being prioritized. They have done a very nice aggressive program on cancers. So those elements have been built up in the NPCDCS program. And also the IHCI. So it's an innovation in itself, so continuous innovation. It's very humbling to see the way the narrations were made this morning by Dr. Abhishek and Dr. Kaur. The evolution in terms of assessments, in terms of innovating around the approaches. So they have adapted the steps and the gaps. And recently the National NCD Monitoring Survey has come up. New studies have been launched. The LASI survey has come up, NFHS 5. Those are also going a bit deep into NCD. So that's a dimension where what I'm seeing is a bit of merger of descriptive studies with much of delivery and development. So you have programs evolving and implementation science and much capacity building happening around that, much harder investment going there. At the same time, some burden assessment linking is happening. And that's even more important because we are now coming out of a pandemic. So sort of all statistics have been reset. And we must know what are our burden estimates. So that's the space where I see that if academia attacks this problem, academia should be able to clearly outline what are the burden, and then in different terms, not just in terms of prevalence or incidence, but in terms of the health economics dimensions or other burden assessments, tallies and callies, those terms. So that we could build a story, a narrative around a theory of change approach that IHCA is perhaps almost evolving into. Now, coming to the discovery space, very interesting development in terms of health technology. So health technology, remote patient monitoring, connected devices, validation of startup products, biotechnology products, point of care diagnostics, data management, moving from paper-based to electronic MIS. Yes, those elements, those are areas where actionable research could be done by academia. And that will immediately start showing results. On the clinician front, 2-3 elements are coming in. The non-pharmaceutical devices for blood pressure management. That's been the talk of the town in the development world, the developed world. And can devices really modulate the nervous system to control blood pressure, especially resistant hypertension? That's one element. The other element is, Dr. Kaur already mentioned, the mixed prescription, mixed dose, yeah, fixed dose combinations, yeah. Those combinations. And some innovations around, like if this is my combination and this is the budget, then for how many days can I provide extended prescription? So if you provide extended prescriptions, 2-3 things happen. One, the health system is decongested, your control increases, and that's even more important in the way the government is operating, where everything is incentivized. So if I see 2 patients, I get this much incentives. So if the contact with health system is decreased, that means the load on the system is decreased, the incentives would come down, and that's where you save money. So those are certain business dimensions. Dr. Sarang is here, so he could reflect better on this. The finance component can also work out by giving out extended prescriptions. So you get health benefits, and so collaborative approaches would be the priority. I congratulate RTSL for having this fantastic panel. You have lead development partners, business, health systems, and then foundations and technology people path. So thank you so much.
Thank you so much, Dr. Archisman. I think you really identified very important research topics across multiple sectors, both in the near term, which have immediate application, but also with a vision from long term, which can really help make things much better for patients, as well as make it easier for health system. So lastly, but not least,